This is the CDOC Cancer Survivorship Research webinar, and I'm very excited that we have two great researchers to present their work. We'll be going over each of those presentations during this webinar. Next slide, please. My name is Shante Davis Patterson. I am the program director for California's Comprehensive Cancer Control Program, which administers the California Dialogue on Cancer, or CDOC. So just a couple of housekeeping notes. All participants have been muted. If you want to ask a question at the end, please unmute yourself. But we do ask that you all put your questions in the chat box. If you have one, we'll be monitoring the chat, and then we'll open up for questions after both of our presentations. As I mentioned, the webinar is being recorded, and we will have an evaluation at the end. And please do fill out the evaluation for us, because it does help us improve these webinars. Next slide, please. So today, this webinar will present how research supports increasing knowledge of the burden of cancer survivorship and issues faced by cancer survivors. We'll hear from USC's Center for Young Adult Cancer Survivorship's work in the quality of life impacts medical outcomes, providing supportive care in oncology and healthcare utilization in young adult cancer patients and survivors, and cancer-related disparities among young adults survivors. From Samuel Oschin's Comprehensive Cancer Institute, we'll hear about their work in physical and rehabilitative needs of cancer survivors who continue to experience the effects of cancer or cancer treatment. Cancer survivorship programs focused on the goal of optimizing physical, psychological, and spiritual resilience for cancer patients. So to introduce our speakers, we are not going to go through the bios, but I'm gonna put those bios in the chat right now. But our first speaker is Dr. Kimberly Miller. She is the co-director for USC's Center for Young Adult Cancer Survivorship Research at the Keck School of Medicine of USC. And then Dr. Asher, who's the Director of Cancer Survivorship and Rehabilitation and Patient and Family Support Program at Cedars-Sinai Cancer and the Samuel Oschin Comprehensive Cancer Institute. Dr. Asher was also very instrumental in helping to develop our treatment and survivorship chapters of the new iteration of our state cancer plan. And I'll post his bio in the chat as well. Next slide. So now I'm going to go ahead and turn it over to Dr. Asher. To Dr. Miller first.
Thank you so much. Thank you, Shante, Roxana, Dr. Asher. Thank you to CDOC for inviting me, and thanks to everybody who is attending. So I am going to talk, as Shante said, about young adult cancer survivorship research. I don't know if I can get through everything she mentioned, but I'm going to hopefully provide some information that will be useful and of interest. Okay, next slide, please. Okay, great. So in today's talk, I'm going to first talk about why we focus on young adult cancer survivorship research, why age matters. I'm going to give you a very brief introduction to our center, and I'm going to talk about survivorship issues for young adults and share some findings from our center, but I'm really going to focus on really one key issue for young adult survivors of cancer, and that is healthcare engagement. Next slide. Okay, so why do we focus on young adults? Why does age matter? We know that cancer survivors of all ages are a vulnerable group with many needs and care needs. So why age? Can go to the next slide, please. So young adults with cancer are, first of all, by virtue of their age and their life stage, a unique population, a highly vulnerable population, and they have distinct medical issues and psychosocial issues and needs. When we talk about young adults with cancer, we're referring to two overlapping but actually distinct subgroups. So those are pediatric or childhood cancer survivors, those survivors who are diagnosed aged under 21. And then we're talking about adolescent and young adults, or AYAs, that is defined by the National Cancer Institute as diagnosed between the ages of 15 to 39. So these groups have, as young adults, many overlapping issues, again, due to age and life stage, but they are also distinct. There's different cancer types that children get often. Childhood cancer survivors are treated in the pediatric care setting, and AYAs on the older end may be treated in the adult oncology setting, but there's a lot of also commonalities between these groups. Next slide. So childhood cancer survivors, the good news is 5-year survival rate has improved dramatically with improved therapies. So it's over 80% now. But the not so good news is that survivors of childhood cancer have significant treatment-related long-term or late effects. So for example, we know from the childhood cancer survivor study that after about 30 years, more than 70% of childhood cancer survivors have some comorbid condition or treatment-related late effect, and 42% of them have a severe or life-threatening late effect as a result of their cancer. So to mitigate this and to provide care, lifelong surveillance is recommended, and that surveillance should be cancer-focused on their risk for long-term effects to prevent and reduce the severity. In other words, to get ahead and mitigate these effects. Next slide. So for healthcare professionals, Children's Oncology Group provides the long-term follow-up guidelines. These are for survivors of childhood, adolescent, and young adult cancer, and there's the link there. They're available and you can have a look at them, and they are looking at both treatment exposure and host individual level factors, and it determines the required follow-up, cancer-focused survivorship need. For survivors on the sort of patient-facing side, that translates into the survivorship care plan, which is a treatment summary of all therapy received and the interval of needed test and surveillance in order to mitigate and reduce these long-term effects, which also can be, I should note, psychosocial effects from the cancer experience. Next slide. So AYAs are a distinct group, as I said, from pediatric cancer survivors. And the field of AYA cancer survivorship was really launched in the early 2000s. And this report, Closing the Gap, which was done by National Cancer Institute in collaboration with the Live Strong Young Adult Alliance, was critical in launching this field. And what this report found was that this 15 to 39 age group, AYAs, had a lack of survival improvement compared with other age groups. Next slide. So if you're familiar with our field, you're very familiar with this famous chart by Dr. Archie Blyer, who's considered one of the founders of this field. And what this shows is along the bottom, or the x-axis, is age of diagnosis. And it's, you can see that this is also relative to the younger pediatric cancer patients and older cancer patients, and it's showing 5-year relative survival. So if you can see, there's this this dip in this 15 to 39 age group, and it's quite dramatic in the 30 to 39 age range. So relative to these younger pediatric patients and these older patients, despite improvements in therapy, these AYAs do not seem to be benefiting from the same survival improvement as other groups. So, you know, the question was, what's going on here with these young adults? Next slide. So recently, these data were reappraised by one of my colleagues and one of our center associates, Dr. Li-Hua Liu. Many of you may know her. She's also the director of Los Angeles County Cancer Surveillance Program, which is housed at USC. And she, what she noted was that the years in which these data were analyzed overlapped with the HIV/AIDS epidemic. And so she re-examined these data, reappraised them, and did sex-specific analyses because she wanted to know what's the effect if you take out the HIV/AIDS related cancers on AYA survival using SEER registry data. Next slide. So I invite you to read this really interesting paper. I've put it here. What Dr. Liu found was that when you remove these, you know, AIDS-related opportunistic cancers, Kaposi's sarcoma, you know, lymphomas, that in fact, AYA cancer survival was actually better than other age groups and improving. And that in fact, some of what we saw in that initial graph may have been due to the HIV/AIDS epidemic. So what does that mean? Does that mean that, okay, you know, we should abandon AYA research? It's, you know, everything is fine in this group. No, they're very careful, the authors, to point out that really what they are intending to do here is to better focus and pinpoint the research we need to be doing in this vulnerable age group. So what they found was doing sex-specific analyses that females consistently displayed, AYA females consistently displayed better survival than males, and they found disparities in ethnic and racial minority subgroups. And a theme throughout this is going to be that our research is very limited in terms of diversity, and most of the research has been conducted among non-Latino white populations. So really what this study shows us is we really need to, you know, the details are in the subgroup analysis. Next slide. Okay, so hopefully I've convinced you that young adult cancer survivorship research is an important area. We think it's important enough that we founded a center for it. Next slide, and I'm going to briefly go through our center. I'm not going to read these, but our mission is to study, improve health outcomes of young adult cancer survivors. And we define cancer survivor, a survivor according to the NCI definition, which is from time of diagnosis until end of life. So a survivor isn't someone who's, you know, for instance, off therapy. And again, we define young adult as, you know, generally diagnosed under age 40 in these two distinct groups. Next slide. So here's our leadership team, the co-directors. It's myself, it's Dr. Joel Milam, who is a professor at UC Irvine. He is, has expertise in this population and healthcare engagement, utilization in this population, and resilience and adaptation to cancer diagnosis. And then Dr. David Fryer, he is a clinician scientist at Children's Hospital. And he actually runs our survivorship services both at Children's Hospital and also at Norris Comprehensive Cancer Center. So the three of us are the co-directors of our center. Next slide. So I won't go into too much about, you know, who we are, but a couple of key points. We're a virtual center. We're not like a bricks and mortar place, and it's really a labor of love. So, you know, this is not a center that we're doing, you know, we don't get paid for it. This is aside our normal day jobs as scientists and clinicians. And we also don't have members. We have associates, people who affiliate. Really what we wanted to do was create a kind of hub to facilitate team science and collaborative efforts, because this population requires you know, multi-site, multi-institutional. I mean, cancer is rare generally, and it's rare in young adults. So we really need to have collaborative, a space for collaboration. So we hold meetings and we also train. Training is very important. We train students from undergrads at USC and UCI all the way to medical fellows who are training in young adult survivorship across our hospitals. Next slide. So I won't go through this too much. There's where, you know, back in the old days when we could see each other in an actual environment. We haven't been there for a while, but these are some of the collaborations we have. And I have my email on this. So if you're interested, please do drop me an email. The other thing I'd like to say is we work very closely with patient advocates as partners in the research alongside scientists. Next slide. Okay, so survivorship issues. Given the time frame of this talk, actually, if you go to the next slide, this will make more sense. Okay, I said that young adult cancer survivors have many issues, and there are many, many things I could talk about. Here are a sample of some of them, right? Body image, I could so just there also because much cancer been to design or where cancer. So I'm really going to focus on one key medical use in a patient-centered way. Drop out of in this patient population. That's a really big right. These are cancer survivors for interval time is the chronic health conditions that develop, and then the blue line is the visits to a cancer center. So cancer-focused care engagement within the past 2 years. And what you can see is that as issues start to happen, there's this dropout from care, which is very concerning and can jeopardize long-term health outcomes. So we know that combined for young adults, more than 40% out of their focused care, guideline recommended care. And that's two, that mostly again, primarily non-Latino white populations. Next slide. At USCI to this issue and to really look at care engagement and now Orange County. So these are two R01 population-based studies. The other thing I should say is that much of what we know from these populations are clinical hospital-based recruitment. So childhood cancer survivor study is all patients who are in care. It's a seminal, wonderful study, and we know so much, but population-based studies harnessing power of cancer registry can also find individual survivors who are not in care. Those are who we really also want to understand what's going on with them. So Project Milestones, led by Doctors Milam and Fryer, is a study that just launched. So I'm not going to focus on that as much, but it's the AYA age range. It's all of LA and Los Angeles counties, and we are looking at potential delays in the achievement of important adult milestones as a result of the cancer experience, and again, care engagement and utilization. But I want to talk about Project Forward. That is led by Dr. Milam. He's the PI. That one has completed, and we are now at the stage of publication with that. I'm a co-investigator. So Project Forward is a population-based study, Los Angeles County. It's childhood cancer survivors diagnosed under the age of 20 with all types of cancer, stages 2 and above. So the recruitment was 1,166 cancer survivers, and 50%, approximately 50% are Hispanic Latinx. So it's an enriched, diverse population. And we also have other racial ethnic diversity of smaller amounts, but we in representing our population mix in Southern California, we have a large population of Latinx survivors. Next slide. So I want to share some findings, what we found. So we found, good news is almost 60% of these young adult childhood cancer survivors are in cancer-related follow-up care. From the pilot study that Dr. Milam did in 2009, this has increased quite a lot, and that spans the years of the Affordable Care Act. So the Affordable Care Act appears to be having an impact on the survivor population, and I think only about 10% were uninsured. So that's the good news. The less good news is that these visits decline with age and years since diagnosis. So again, we're seeing this pattern of attrition from care. We're also finding, again, this risk group of non-white patients, so Latinx and patients from other racial backgrounds are not in cancer-focused care. And overall, what we found was few of these young adults are receiving what we would call gold standard care. So survivorship care plans, discussion about their long-term care needs, regular access to care. We did identify that healthcare self-efficacy, or the perceived confidence to be able to navigate our fragmented healthcare system, is a protective factor associated with being in care. So that's a potentially intervenable factor. Next slide. So this gives you a little bit better of a visual story here. So this is the Project Forward cohort and the proportion who report a cancer-related follow-up care visit in the prior 2 years by age and gender. So what are we seeing here? We're seeing, of course, again, that decline over time with age. But if you look at the males, that's really an issue. And males generally, we're finding with young adults have worse survival than females. You know, what role does this play in the survival outcomes? So we have a man problem is the issue, and we need to target these young males who are dropping out of and not getting care. I don't have the slide, but if I were to disaggregate this further into racial ethnic groups, what you would find is a steeper pattern, again, with non-white childhood cancer survivors who are young adults accessing less care and not getting sufficient cancer-related follow-up care. Next slide. So I'm almost at time, but I do want to just make this available to folks, because if you're interested in disparities and barriers in this population, Dr. Erin Mobley, she's an assistant professor now at University of Florida, but she was our first center-trained postdoc. And so we're very proud of Dr. Mobley. Dr. Milam and other colleagues produced this report that was funded by AHRQ and NCI about disparities and barriers to pediatric cancer survivorship care. They've also just published a scoping review in the Journal of Cancer Survivorship. So I'm not going to go into this. I want to, retain time, but I did want to show you where you can download and read this very excellent report. Next slide. So how can we improve outcomes? I've barely touched on, a host of other psychosocial issues here, but in terms of just some general thoughts, we need expanded research. We need larger cohorts. We certainly need more ethnically, racially diverse samples in which to conduct our research. We need to retain these young adults in care. We need to specifically focus on risk groups, males, non-white populations. We need improved care coordination that's age tailored, and also advocacy and policy. I did not go into things like fertility and reproductive health, but that is a ripe and rich area for advocacy, and as well as financial cost of care. These are two other very important areas that I didn't have time to go into. Next slide. This is what's coming up next. So we have a lot of interesting work ahead of us. We are going to be exploring care engagement among Asian, American and Asian immigrant childhood cancer survivors, and look at the effect of neighborhood. That's our next project across both LA and Orange County. So we have a whole bunch of things that we're going to be doing. Next slide. Okay, I hope I didn't go over time. I just want to thank everybody. Thanks, CDOC, the whole team, and take it away, Dr. Asher.
Thanks, Dr. Miller, for starting this conversation. I think we have a lot of parallels in our worlds, obviously. And thank you, everyone, for joining in, for the opportunity to be with you. I'm a rehab physician by training, so I think it colors, obviously, my background colors how I see the world of survivorship. And in the next few minutes, I'd just like to give a very high-level overview of some of the programs and associated studies that we've launched to try to address the survivorship needs within our community. Next slide, please. And as you could imagine, this is an issue not just for us in our community. I'm at Cedars-Sinai in our area, but there are more and more cancer survivors, around 17 million today, with the number expected to grow, as you can see, over 20 million by 2030. Next slide, please. And I think the other point that I think is especially important that we often relate to our medical students when they rotate with us, or residents, is oftentimes when we're in med school, as you know, we often think about 5-year survival rates, often forgetting that today, for many cancer types, there are survivors who have lived 5, 10, 15, 20 years or more after a diagnosis. And if you think about it through this lens, obviously I'm biased as a rehab person, survival alone isn't important. It's all the quality of life issues that really make a full and longer life meaningful. So next slide, please. And the Institute of Medicine in 2007 or 8 published an important report, and echoing and many of the things that Dr. Miller alluded to. There are physical issues, psychological issues, psychosocial issues that obviously the AYA have their own important heightened issues that they have to contend with, but I would argue that all of our survivors have to contend with many of these issues across the board. And so with the next slide, I'd just like to introduce that our Wellness Resilient Survivorship Program, which I'm a part of, is just one part of our greater patient and family support program. So we're made up of exercise trainers and yoga instructors and other people in our wellness program, but we have many social workers and psychiatrists and palliative care physicians and chaplains and whatnot to try to contend with many of the issues that we know our survivors may be dealing with. And so for the next couple of minutes, next slide, please. I just want to highlight just a couple of our programs. Again, as a rehab person, I'm biased, but we know that exercise is medicine. And the next slide shows basically a nice infographic, and if you haven't seen this, I think it's nice to have available to your patients, because in one little sheet, it outlines the high level of evidence of exercise for a variety of issues that our survivors experience, such as fatigue and anxiety and whatnot, highlighting at the top of how many of our common cancers, breast, colon, and prostate cancer, possibly others, are believed to have improved survival if you get the right amount of exercise, which is believed to be about 150 minutes or so per week. The challenge being, with the next slide, that many of our patients don't know how to start or how to achieve and integrate this kind of activity. So what do we know? We know that women decrease their activity by 2 hours a week after a diagnosis. Next. And this is amazing. If you look at women after finishing chemo and radiation, 3 years later, and you look at their cardiovascular fitness levels, it's as if they have aged 20 to 30 years. And this is important because this is potentially modifiable with the right exercise interventions. And again, as a rehab person, this bothers me. Many studies have shown that only about 20% of survivors recall having a discussion about the benefits of exercise with their provider, despite all these benefits that we can spend a whole hour talking about. So next slide. So given these realities, one of the programs that we launched, which is different from physical therapy, because physical therapists tend to just focus on some musculoskeletal or functional issue, but we started our cancer exercise recovery program, which is an individually tailored 36-session program, really aiming to optimize fitness and strength after going through a cancer diagnosis, where we can account for, again, blood counts and lymphedema and bone metastases if they exist and that kind of thing. And I think this has been a great way to catapult and launch many of our patients into hopefully maintaining a home program on their own. Next slide. One study I just wanted to mention that we're actually just launching right now, because we know that exercise is good, and there are many hundreds and hundreds of studies that have shown that it's helpful for our cancer survivors. The location and the setting where we exercise, I don't think has been as well studied, at least not for cancer survivors. And so we're starting a pilot study where we're having our survivors actually walk in a green space in one of our local parks. There's a picture of it right here, and amazingly, you could find green space in LA still. And so not just looking at quality of life issues, but actually markers of biologic aging with DNA methylation and inflammatory cytokines. And Dr. Miller, I should mention, we're actually launching an AYA sub-study. So I'd love to make this available to your patients for 18 to 39. And then once we're done with this, we're hoping to do a larger study where we randomize people to like a gym-based program versus a nature-based program with the identical intensity and duration of exercise, but seeing if the physical environment changes any of these important outcomes. Next slide, please. So-called chemo brain, I put it in quotes because we know it's not a probably very accurate term because there are many factors other than chemotherapy that may contribute, to the next slide, to the cognitive symptoms that many of our cancer survivors experience. I think, as we all know, these are common symptoms: word finding difficulties, multitasking challenges, short-term memory, attention concentration. There's no single symptom that is pathognomonic, but it's a common set of concerns for many of our survivors. And if you go to the next slide, and this is just basically an image from NCCN guidelines. And it's intentionally a busy slide because I would argue, I don't know if there are any oncologists in the audience today, but these are the recommended steps that clinicians take to try to contend with these side effects. And I could tell you, this is very hard for our colleagues to do because they're so busy as it is. And I know it's very hard to take into consideration all the different suggestions to try to optimize cognitive recovery. And so one of the other programs that we developed about 8 years ago, and you can see with the next slide, we call it Emerging from the Haze, where I've partnered with our neuropsychology colleagues, and we've basically tried to straddle together all the different recommendations that were suggested by NCCN and based on our experience in terms of the role of mindfulness and stress management strategies and memory strategies and compensatory strategies and the role of exercise and cognitive recovery. And we kind of packaged it together into a 6-week program that we've been running for a number of years. And with the next slide, it shows one of our earlier studies where we basically had a prospective study comparing our Emerging from the Haze group to a waitlist control, and basically looking at subjective cognitive symptoms, which in my belief is really where the issue is. It's a subjective experience for the most part, and not objective neuropsych findings that you find. And we found, again, that from a quality life perspective, people improve with their subjective experience from before and after, and seem to maintain some of these benefits over time. What we're really focused on next with the next slide is not just helping our group of 12 or 8 people, how we kind of support the program here locally, but see if we could disseminate this more broadly. So we're actually creating a video production of the program, with the idea that we can disseminate this and share this with our partners, locally, nationally, to see if having a pre-recorded adaptation that could be delivered locally can be as effective as what we found with our initial studies. And so this study is actually being planned and underway with my colleague, Jamie Myers at the University of Kansas. Next slide, please. The other hot term in the cancer rehab world is actually cancer prehabilitation. Next slide. This is in my mind not rocket science, but I think one of those common sense ideas that historically we didn't take advantage of. Basically, it's this idea, for example, that let's say we know someone's going to have a bone marrow transplant in 2 months, because it's right. Nobody has a bone marrow transplant tomorrow. There's usually some time being planned and worked up to that big day. And so the idea would be, let's say you had 2 months or a month or 6 weeks, that you would leverage that time to try to improve their physical strength and introduce some stress management strategies, optimize their nutrition as best as possible, with the idea that you're providing some buffering to the insult that we know that they're going to be experiencing when it's their surgery or their bone marrow transplant or whatever it may be. So what we're doing with the next slide is we're actually starting a prehab study specifically for our patients with pancreatic cancer, because at least at our setting, we have a fairly decent pancreatic cancer program, and we know that there's profound debility and cachexia and weakness that occurs for many of our pancreatic cancer patients. And so given that many of these patients are receiving neoadjuvant chemotherapy, so there's some time before surgery, that we can try to intervene with an exercise program, a nutritional program, stress reduction program. Next slide. And so this study is actually being worked through the IRB right now, where we're leveraging our exercise trainers and physiologists for a tailored program that's going to be in person for 6 weeks, and then for the following 6 weeks, a hybrid of virtual and or in person, and we'll be looking at, again, some patient-reported outcomes, some objective markers of strength, and really looking at length of stay and postoperative outcomes and complications to see if maybe we can shave off some costs and downstream complications by, again, optimizing their strength going into the surgery. So this is another study that we're excited to get started hopefully soon. Next slide. Another program that we developed that, again, is a personal passion of mine, we call it our GRACE program, which stands for Growing Resilience and Courage. Next slide, please. And this is basically a program to try to address the existential piece, right? The piece that we know many of our patients experience, where they are suffering on a soul level to some degree, whether it's feeling disconnected, feeling like you lose your sense of control, having a crisis of meaning or whatnot. And even though I prescribe antidepressants and benzodiazepines and Xanax and things of that kind, I would argue these medicines in and of themselves will not address the profound existential issues that we know our patients, many of our patients may be experiencing. Next slide, please. And so we developed a program which, again, GRACE, that is currently designed as 6 sessions. It's a bit of logotherapy, which I'll discuss in a second. It's a little bit of cognitive behavioral therapy, some positive psychology, mindfulness, etc. Next slide. The logotherapy piece, I know many of you may be familiar with Dr. Viktor Frankl. He wrote an amazing book that I hope everyone would have a chance to read. It's called Man's Search for Meaning. His basic tenet was, and I'm simplifying a profound book, that if you can find a sense of meaning and purpose in your suffering, you can rise above anything. And so we read excerpts from his books together, and his basic idea was that one can find meaning in your work through acts of love or through acts of courage, particularly through difficult times. And again, we integrate a lot of his work into the GRACE program. Next slide, please. I was also personally influenced greatly by Dr. Rachel Naomi Remen, who wrote My Grandfather's Blessings and Kinship Table Wisdoms. She's really a master in providing, a poetic art of perspective, particularly with in context of her own chronic illness. So we've integrated some of her work. Next slide. And so there's this curriculum that is standardized. So it's not being run, and you can go through the different weeks, not being run as a support group, but rather a curriculum where we go through through 6 weeks of these different ideas to provide strategies with the ultimate goal of optimizing resilience. We just finished our randomized clinical trial that you can see with the next slide, where again, we looked at patient-reported outcomes. This was with myself and my colleague, Dr. Jeffrey Wertheimer. We can go to the next slide. We had 60 individuals with a metastatic cancer, most of them breast cancer, randomized to the waitlist or intervention group. And all this shows is that that at least for the short term, 1 month post the intervention, that there was an improvement in spiritual distress and general well-being with the measures that we used. And we're working on getting this manuscript out right now. Next slide, please. We have another study that unfortunately is on hold with the pandemic, because I don't want to do improv via Zoom, although I think you can. I'm just worried we'll miss an effect. Where we have our, we developed an improv curriculum from one of our expert patients. Next slide, please. Where there's this idea that improv, really can theoretically at least be helpful to many of our cancer survivors, because and again, I'm not an improv expert by any means, but the idea that you don't have a script and you have to react to what the cards you're dealt is really, in a way, an improv skill. And there's been studies in other populations that it could be really helpful with anxiety and distress. And so we had a pilot study, which was really quite amazing with our initial pilot data. And so we do have our randomized clinical trial that we started, and then we had to put on hold for the pandemic. So hopefully we could start it later this year if the numbers go down. So we'll see. Next slide. And then the final study I'll mention is we have a Qigong program, which we know is helpful for a number of symptoms, but we're specifically interested in looking at it with our pilot study for chemo-induced neuropathy. Next slide, please. And we know that chemo-induced neuropathy for some people may cause pain, for other people it may cause balance and functional issues. And so we're really interested in seeing if Qigong can at least possibly be helpful for both issues, the neuropathic pain issues and some of the balance and functional measures. So this is more of a preliminary data gathering trial to see if it makes sense to move forward. Again, we started this, and then because it's a group program, we had to put it on hold. And the next couple of slides, you could just really fast forward through, because it was just meant to share in kind of graphic form some of the programs. This is just from our flyers that are available to our patients. We've been able to pivot and offer most of these programs virtually, which has been nice, given that this has been going on for some time. But we look forward to getting back in person, because we know the social connectivity piece is important. So that's it for me. Thank you so much. And again, I think Dr. Mill and I would love to take questions if there are any.
Great. Thank you both, Dr. Miller and Dr. Asher. Those presentations were wonderful. And I know that I've learned a lot about a lot of the research that's going on. So thank you for sharing. We do have a couple of questions in the chat. I just wanted to note that there have been some links inserted in the chat. I inserted the article Dr. Miller referred to, and then there's the scoping review that was also inserted. So I'll go ahead and read the first question, which is to Dr. Miller. I'm sorry, to Dr. Asher. And someone asks, they're curious about how you'll control the intensity of exercise in the nature setting for the program you were referring to.
Oh, great question. So we have an exercise physiologist, so we're going to develop a target heart rate to reach the moderate intensity program for each person. So it's going to be each person will have their target heart rate. We're going to try to group them. So if you have we're going to try to have groups where you have more fit and less fit kind of clustered together in groups of 2 to 3 to 4 or 4 at the most, so that they'll have similar paces and still being in the moderate category. And then again, when hopefully if we're able to do the randomized clinical trial in the future, we're actually measuring the incline grades on the trail so we can reproduce that on the treadmill in the gym, so that the duration, the intensity, and the frequency, which will be 3 times a week, will otherwise all be as identical as we can make it, with the idea that really the only difference will be the setting. And we'll see, will it be the same, or will we find some differences? And I'm personally kind of eager to see what that will show.
That's really, really interesting. Thank you.
All right, I actually don't see any other questions in the chat. So if anyone wants to come off of mute, please do so and ask a question.
Hi, this is Sherry from Orange County Herald Center. I'm amazed with those programs, and my question is just how are those programs being made available for Chinese community Orange County, because that's the community that our organization is caring for. Would those be made available in Orange County as well?
Thank you. And if I may ask a question, I don't want to be presumptuous. And so we're working on making it available broadly. So right now we're doing Grace by Zoom. So we've actually had people from Seattle, New Hampshire, and whatnot joining. But do you mean available in Chinese, or available just geographically in Orange County?
I think first I will look at the people that in our community, they are people can do it in English, but eventually I would think the underserved would lie into the people that lacking of the language and culture. And then so that's what mostly our agency do to gap those differences or challenges.
That's a great point. So our first goal actually has been similar to Emerging from the Haze. I mentioned we're working on a video production. So we're actually working with a company that are experts in actually almost making it like a movie-like experience so that it could be disseminated broadly. We're going to do the same thing with Grace, I hope next year, after we finish with the Chemo Brain series. Now, the question that you bring up is, yes, I mean, especially Grace, it's so nuanced when you talk about existential issues that you have to have a firm grasp of the language to grapple with the text from Viktor Frankl and Rachel Remen and whatnot. And I know our own team here at Cedars has mentioned, the idea that, it would be nice to be able to offer this in Spanish. We have a large Korean community locally and certainly Chinese. So I would love to, maybe if I'll share my email. If we can think of ways of partnering with community resources to translate the content, I would totally welcome that opportunity if we could think of ways of achieving that. Our goal was to share this. If we have it translated in a viable way, I'd love to explore that.
Great. I think that would be so beneficial for a lot of cancer support group, because what I'm thinking about, because we have a breast cancer support group and in general, all types of cancer support group, and also program like that. It would be so good to introduce to our survivors.
A great point. And if I may just comment one further detail, and as I mentioned, I'm all for support groups, and I think it's helpful for many people, but I will just say, many of the individuals who come to the Grace program or the Emerging from the Haze program or whatnot, they were actually drawn to it because it's being kind of advertised as not being a support group, as just being a place that you can come to learn strategies and techniques, almost like a class. Because, and I think and the literature suggests that some, not all, some people may actually feel more distress when you just go to an open support group where you just kind of are, just freely expressing things and kind of comparing your situation with someone else's situation. So I think as long as we can keep that spirit of this as being a structured curriculum that can be translated and offered in different settings, I think that would be that would be a great opportunity to think through. And I left my email in the chat.
Yeah, I get it. And I think for us, run support group, part of the big part is to navigate or connect resources, not just bringing them into the group, but also refer them to all the helpful resources. Yeah, so this will be great. Yeah. Thank you, Dr. Asher.
Thank you.
Okay, we have another question that just came in the chat for Dr. Asher. Will the type of outdoor setting also be assessed? Curious if you'll look for potential differences when exercising in an urban versus park-like setting, running in the neighborhood versus out on a trail.
That's a great point. And, you know, I mentioned the reason I thought of this study originally before I partnered with, again, my colleague, Selena Shirazapour, was I would be walking home, leaving, I don't know if you know the LA area, I'd be walking through La Cienega and 3rd Street, and I'd see people jogging on the streets. It's a busy urban area, and people would be jogging and riding their bikes and whatnot. And on the weekends, I would go to where we're going to run the study, which is in Franklin Canyon. It's this kind of, it's in the hills, and you wouldn't believe you're in LA, but it's basically tree canopies and very, very kind of a green type space. And you're right, it does introduce a number of variables. So how much, if there is a difference, which I think there will be, but we'll see, how much of it will be just being out of the direct smog, which could be just one factor, versus being in a green space, away from, people and the hustle and bustle and the noise pollution and whatnot. So we are going to factor in smog levels. We are going to measure that each day that they're walking and take that into account and have an average level looked at. But you're right, there are all these variables that are hypothesized in the green literature in terms of air pollution versus actually seeing green space versus, the spiritual aspects of being in nature and whatnot that will need to be sorted out. I think the reason we chose this setting is we're capturing all of those elements in this local park. It's quiet and it's green and it's away from direct traffic and smog. And if there is a difference, then maybe we could argue later, which facet is it? But we just didn't want to lose capturing an effect at this early stage. But point well taken.
Great. Do we have any more questions? We do have a couple of concluding slides here, but if there are any other questions, we can take them now.
I just have a quick comment about Dr. Miller's presentation. It's really helpful for me because I have not exposed to the adolescent and childhood cancer before our organization, but this has surely inspired me for developing like support service to families that have this need. And it's like eye-opening, 40% drop off the care system. Yeah, so a lot of new things I've learned from Dr. Miller. Thank you very much.
Thank you, Sherry. I appreciate you being here.
All right. Well, we all appreciate your presentations, Dr. Asher and Dr. Miller. I think everyone has learned something here, and I'm happy that we're able to connect some of the participants with you as well, because that's the point of all of this. Can we go to the next slide, Roxana, please? And on that note, CDOC does have a survivorship work group. We meet virtually every first Monday of each month from 12 to 1. If you're interested in joining, please send an inquiry to our Gmail. You'll see right now our areas of focus are resource sharing, resource listing, and patient and provider education. We're still working out exactly what our work plan will be for this work group, but the intent is really to implement the objectives in the new 2021-2025 cancer plan. So we've only had a couple of meetings thus far, but please join us if you're interested. We'd love to have you. Next slide. And then in talking about the cancer plan, we do have a webinar series that we're rolling out. Our next webinar is on health equity, and that's next Thursday, July 8th from 2 to 3. So if you're on the CDOC listserv, you'll get that notification. We have promoted this webinar, so the registration is out there. And the next slide, please, Roxana. And if you're not on the CDOC listserv, please do get involved with us. You can get involved with our work groups and other coalition efforts we have going on. For example, right now we're working on a collaboration with cancer centers in California. We also have a website right now that is being updated. So you can go to cdoconline.net right now, but some of the information is outdated, but I will let you know that it is being worked on. And the next couple of weeks, we're hoping to reveal the new website with all of our updates, including tabs for the new cancer plan, as well as recordings for all of the webinars that we have presented. This webinar recording, as well as the others, will go out on the listserv as well, but in the future, we'll have a place to house all of them. So just know that it is being worked on. And again, if you have any other inquiries or want to get involved, you can send an email to cdocshare@gmail.com. And lastly, as I mentioned, we do want your feedback. So I'm going to drop the evaluation in the chat, and please do fill it out for us. I want to thank again Drs. Miller and Asher for joining us. And I also want to thank Roxana Bautista, who is our consultant from Rise Up Solutions. She's done wonderful work with us just over the past year and a half or two, and for years volunteering with CDOC. So we're very appreciative for her. And again, to our presenters, and thank you very much for everyone who joined for this webinar.